All right, guys. So today we're gonna talk about a super duper high yield topic for USMLE step 1 and 2. So if you guys want to know a very easy way, I simplify this topic, this high yield topic, and that causes a lot of people so much confusion into easy steps so you can identify the main diseases. In a way, you can select the correct answer. So we're looking for correct answers and scores improvement. So one framework to solve most glomerular diseases, nephrotic versus nephritic. Remember, all before I in this case, so protein and I for inflammation. What I really recommend is that you draw this scheme in your notebook or whatever and make sure that you can explain all those beautiful things for yourself, so you make sure that you're not just doing you wrote questions or whatever, and you're getting increasing your score by knowing it in your mind. All right, so what you're gonna see is lots of the positions: immunocomplex, antibody plus antigen, and complement. So these diseases, they involve lots of the position. So in nephrotic, we lose protein, and in nephritic, we have inflammation. So let's move on. First, we have to understand this simple principle, and this occurs in inside our kidneys, the nephron. So there is a barrier here. You see those endotheliums, if you remember the Bowman capsule and those glomerular, those you can remember those spaces. They have those endothelials and lots of blood vessels inside, and they have this filtration barrier. So the filtration barrier, the blood passes here and that goes through the endothelial cells, and they pass the basement membrane and the podocytes. So this barrier is used to make urine basically. So the blood gets filtered and then it goes through the kidneys. You guys can pause the video and read this, but this is something we're gonna use to explain how the immunocomplex or the or whatever deposits here. So sometimes they deposit over here and make the V shape down. I just forgot, but you will see they can deposit anywhere under this or here or here. So this helps us classify based on pathology those kind of diseases. So where can immunocomplex deposit? So this is key. If it deposits subepithelial, it's membranous or Post-Streptococcal Nephritis. This has a different name nowadays, and they can use on real questions. And intramembranous, let's get back. So it can deposit here in the base membrane, intermembranous, or here subendothelial or subepithelial right here. So let's I can explain this in more details as we move on. So, yeah, this is the basic structure I want you to remember. So, nephrotic, you lose protein. You have edema because protein it sucks water. Let's say this way. You also produce a lot of lipids because you're losing protein. Your body is trying to maintain the equilibrium, and you also lose anticoagulant factors. So in nephrotic, you can have hypercoagulable state, and in nephritic, you have inflammation of the glomeruli, so you get hematuria, white blood cell casts, hypertension, and oliguria. So if you see blood in urine, that may be nephritic. And if you see that that little kid that has edema around his eyes or in the body, think nephrotic. So nephrotic framework, podocyte diseases, minimal change disease, focal segmental glomerulosclerosis. So those names are really hard, but you can get used. So immunocomplex diseases, membranous MPGN, and systemic diseases, diabetes amyloidosis. So this framework is, we can divide this way, so it's pretty easy and simple to visualize. And then when you're explaining to yourself, you're drawing your own scheme by dividing this way. It will make you it very easy to identify questions and answer them correctly. So minimal chain disease occurs in children, and it's associated with Hodgkin lymphoma. I tell why, because Hodgkin lymphoma produces lots of cytokines, and those cytokines um, produces inflammation, and inflammation will lead to food process effacement. So this leads to selective albumin loss, and because it's driven by cytokines, it has excellent steroid response. So minimal change disease is especially common in children, and it's the most common reason why kids get nephrotic syndrome. So if you work with kids and they get like edema around their eyes, you can suspect, oh, maybe this is because of minimal change disease. And focal segmental glomerulosclerosis, you just see that the glomerulus itself, like the round shaped structure, it's like you divided it into segments, and one of those segments can get sclerosed, and those kind of material over it, and the glomeruli get um, like damage. And but the thing is, it's like a progression from the MCD to FSGS. So this is why we put them together. Sorry, guys, we have to hydrate ourselves. So it's kind of evolution of MCD that doesn't respond to corticosteroids. So this is very important because the pathology seems very similar, but when in your test, you're suspecting a patient with HIV or heroin user or sickle cell disease and they have nephrotic syndrome, you can start thinking about FSGS and MCD for kids. So also African American and Hispanics. And the thing is, it has poor steroid response. Membranous nephropathy is it's in the second group, so you start getting the deposits. So here the deposits itself from immunocomplex are starting. So HBV, HCV, I would say mostly HBV with nephrotic syndrome, and solid tumors, SLE, but SLE most commonly is diffuse proliferative glomerulonephritis, so it's nephritic. But if you see SLE plus nephrotic, you start thinking about membranous nephropathy, although it's not the most common one. So what happens? You have PLA2R antibodies. I don't think it's important for the steps, but just to let you know. So those deposits are made of antigen plus antibody, so they produce immunocomplexes. They are deposits that sub epithelial. So uh, I think around here. So the epithelium, the podocyte, the food process, this area. So they're gonna deposit over there, and they will form a spike and dome on electron microscopy because the podocytes really like to be in touch with the basement membrane. So if you form some deposits over here, what's they're gonna do? Okay, you got the deposit over here. I'm gonna produce some basement membrane and I'm still gonna be in touch with the basement membrane. So what happens is you have your deposit here. I'm gonna produce extra basement membrane layer. So I'm gonna keep in touch and I'm producing a V shape, dome shape. So this is why. And the spike and dome, right? So they produce those spike and dome shape and create a basement membrane in a V shape. You guys can imagine it's not hard. So immunocomplex push podocytes away, podocytes lay down new base membrane, spike and dome appearance. So if in the question stem they use this term, this buzzword, spike and dome, probably they're talking about membranous nephropathy. So let's keep going. MPGN, membranous proliferative glomerulonephritis. This is most commonly a nephritic syndrome, but you can also remember it nephrotic. So in this case, we have subendothelial. It's not subepithelial, it's subendothelial, and this happens right here. So in this region, we're gonna have deposits. So it's all about deposits, guys. And mm, it's nephrotic or nephritic. USMLE most nephritic, although and it has different subtypes. So the type one, you're gonna have like the mesangial cells next to the endothelial cells, and when you have the deposits, the mesangial cells will just produce uh, some collagen, I believe, and this collagen will cross over those deposits and produce a tram track, like literally. And in the type 2, you're not, it's a complement deposit. It's not antigen plus antibody. So it's a little bit different. And in this case, the problem is you have antibodies that stabilize the C3 convertase, and the C3 convertase actually will produce more complements. So if you have antibody that provide the support to the C3 convertase, you're actually producing more of those um, complement. And by producing more complement, what you're doing, in fact, is you're increasing the inflammation in the area. So inflammation leads to nephritic. All right, you got that right. So MPGN type 2, you have C3 deposits, so your C3 levels will be down, and it's different from membranous and type 1 MPGN. So inflammation plus damage to glomerulus. So we have a little memory hook. If you see Hep C plus red urine, you can assume that this is MPGN. So Hep C, red urine, MPGN, until proven otherwise. And just to illustrate what I've just said, so you have the C3 nephritic factor, and the C3 will bind to your complement stuff here and allow them to work. So in this case, it is stabilize and produce those excess C3 and C3b and produces inflammation. So you allow more cleavage of C3 and complement consumption and glomerular and inflammation. All right. So uh, there are some clinical associations, but we can talk about this later. So diabetic nephropathy, you will increase in diabetic nephropathy. You as you have a lots of glucose. Those glucose, they can glycosylate proteins, and if that happens in your kidneys, you're gonna have non-enzymatic, no need for enzymes. It just happened. Non-enzymatic glycosylation of the basement membrane. So you have hyaline arteriolosclerosis. And what this it it comes like with a hyperfiltration injury because lots of glucose is passing by and with this glycosylation too, so you have mesangial expansion. Mesangial is like those cells that surround the capillaries where the filtration occurs. So by having those kind of those material accumulated. So you have chemostil Wilson nodules. You have mesangial sclerosis. So this is a buzzword, and actually the image, if you see just for one time, you can memorize, and it's pretty straightforward. If you see that kind of image, you can actually say it's diabetic nephropathy. And also the questions them, uh, they will give you hints toward uh, that path, you know. So what else we can say about this diabetic nephropathy? So the afferent arterial gets more of damage more than the afferent. So you get this hyperfiltration that leads to uh, arteriosclerosis. In amyloidosis, you have systemic amyloidosis, so amyloid's deposition. You see, guys, this word is key, that position. So it's a different one, but it's still the position. So you have amyloid's deposition in mesangial. And in this case, these work, those words work like buzzwords. If you see Congo red positive, Apple green birefringence, systemic amyloidosis, they happen throughout your body. It can deposit anywhere, even in your heart. So if you see those kind of buzzwords, you figure out that will lead to the correct answer. So for the nephritic framework, so you see, we talked about uh, the nephrotic, like in three groups, pretty easy. And now, actually, in the questions, you after you create this, uh, if you create this frame and you put those three, you have to know they're nephrotic. So you won't get confused on your exam day because there are a lot of psychological pressure, psychological going on, and you're nervous, so you have to be very well prepared. So you better have that crystal clear in your brain. All right. So nephritic, you think about blood, inflammation, hematuria, and red blood cell casts. We already introduced you this concept. So this is extremely important. I would say in this slide, uh, we see children for both of the diseases, but the key difference is because PSGN you have 1 to 3 weeks after the disease. So in this case, Post-Streptococcus pyogenes group, uh, it's group A, because group B, of course, is for babies. So it's uh, post. You can have pharynx or skin infection, but skin is not preventable, uh, and pharynx actually is. If you treat the pharynx, you won't get the infection. Or sorry, the problem in the kidney. So in this case, the you're forming subepithelial. So subepithelial, sorry. So subepithelial in this region. So this is epithelial, endothelial, and basement membrane again. So in that region, you got those subepithelial humps, and the strain of the pyogenes that causes is with the M protein. This is a virulence factor, and you don't need treatment. Most cases, it just gets better by itself. And in for IgA, it's a little bit different. It's post-viral most of the time. And the key different is because it's 1 to 3 days, guys. So remember, post-viral, post-viral, and 1 to 3 days, you have blood in your urine. Remember, nephritic is like blood in the urine. It's IgA until proven otherwise. So mucosal infection after 1 to 3 days, not 1 to 3 weeks, it's IgA nephropathy till proven otherwise. So here we have mesangial deposits. Of course, we didn't specify. All those kind of deposits are like mesangial. And RPGN is just, how can I say it? It's like an upgrade of the nephritis. Maybe I'm not correct, but maybe I am. So the thing is, it leads to renal failure. So if you don't treat it, uh, you're in trouble, all right? So you have hemorrhage plus necrosis, and you can see those crescent-shaped formation, basically because of macrophages and fibrin deposits. You do biopsy, and in this case, after you do biopsy, you do IF, immunofluorescence. So this will, by the immunofluorescence, we have three like groups, and one is Goodpasture, the other one is immunocomplex like the PGN or PSGN, and the pulse immune. Pulse means you don't have like deposits at all. So no immunofluorescence pattern, I think. And Goodpasture, type 2 hypersensitivity, anti-GBM or anti-alveolar basement membrane. So alpha 3 chain, collagen 4, type 2 reaction, antibody against antigen. So 234, the good pasture marches through the field. 234, the good pasture marches through the field. And in the immunofluorescence, you have linear pattern. All right. So if the guys in the stem has hemoptysis and hematuria because it damages both the kidney and the lung because of anti-GBM and alveolar basement membrane in the lungs and the kidneys. Type 2 hypersensitivity reaction. 234, the good pasture marches through the field. I think there was a U here. Sorry about that, guys. Pulse immune RPGN. Little or no immunocomplex deposition, negative IF, so negative, this is key. So after you do the negative, you do the onco test. So the difference, for example, if you see a question where you have, I would say, blood from the nose or pharyngeal symptoms and blood from the up airways, but also with nephritis, you could say, that could be Goodpasture or Wagner. So Wagner has negative IF, and then you do the ANCA test after that. So it's they have different IF starting. First point, different IFs. After that, you can assume that you did a ANCA test. You can differentiate because the ANCA test, as you can see here, the patient's serum containing ANCAs is incubated on a slide with fixed neutrophils. Antibodies bind to either nuclear antigens or cytoplasmic antigens. So the P ANCA is perinuclear and the C ANCA is cytoplasmic. So this will give you different patterns, and by these patterns, you know the common associations with them. And then when you see C ANCA, it's probably because of Wagner. And when you see P ANCA, it's Churg-Strauss. But Churg-Strauss is way easier because you know eosinophils and asthma plus nephritic syndrome. I would just go for Churg-Strauss, you know? So in this slide we have some other points here, but I think that the big picture is that. So Alport syndrome, I would use a mnemonic I created. You say audiovisual port syndrome, and it's an inherited collagen 4 defect. So this is pretty important. I cannot stress that enough. This is a collagen defect, and Goodpasture is antibodies against the collagen. It might have no inborn and no inherited collagen defect, but you still have antibodies against it. So it's not a problem with the college you were born. All right. So Alport, audiovisual port syndrome, inherited collagen 4 defect. So you have, of course, by our mnemonic, you don't need to be a genius to infer that, but you have audio, hearing loss, and also you have eye abnormalities. So those here are just fancy terms: anterior lenticonus, dot and fleck retinopathy, corneal abnormalities, and you also have hematuria because it's nephritic. So whenever you have hematuria, most of the time that I think you can infer that it's just nephritic. And AIN, this is allergy of the kidney. So you have fever, rash, and you can think, oh, maybe this is Sherry straw. No, not always, because this comes from uh, NSAIDs, penicillin, cephalosporins, diuretics. They will say in the question stem, and also you don't need to have asthma. But one of the things they can try to trick you is to say leukocytes on urine and a lot of leukocytes, but it's eosinophil. They didn't specify, but it is, you know. So this is a way they can try to, and because you have this lots of information and you have to decide which one, you have to do your questions. I agree, but if you do a table or a frame where you can do your questions and you have that in your mind to compare, okay, this one, oh, this refers to that disease or this disease, I think it's way easier. So this is why I think this class is very useful for your test. So I think it's one of the last slides. So yeah. So ATN and papillary necrosis. So ATN, I'll tell you a history. Uh, If you see a patient that had a trauma or they did a surgery, lost lots of uh, tons of blood or lots of ischemia, shock, those kind of setting, you will think about something that is affecting like really hard and acute, strong acute event. This is ATN. Don't think anything else. It's very acute, very strong. So you will see the muddy brown casts. So this is very important, muddy brown casts. And for papillary necrosis, this is the papilla. It's a different area, or your kidneys. ATN is acute tubular, so tubes, and papillary, papilla. And you will see a different setting, of course. Sickle cell, analgesics, diabetes, pyelonephritis. So you can see a case where you have pyelonephritis. So I have this mnemonic here. It can save you time. Sickle cell, analgesics, diabetes, pep, pyelonephritis. So I think, and also I'd uh, recommend you observe that there are several intersections. So you see, if you use a drug, it can cause papillary necrosis or it can cause um, papillary necrosis, AIN, and but they you give you hints for you to decide the best answer. And as you do the exercises and you pay attention to the most buzzwords or the most important hints, you are gonna do good. But if you have this frame in the back of your mind and you do exercise together, this is super duper high yield and important. So ATN, there's papillary necrosis. Of course, I'm not gonna read it to you, but you can pause the video and do your notes. It's just to make it easier for you to visualize. And here, I think it's the last slide. I made a compile of information regarding each of disease. It looks like first aid is scary, but you can. I'd recommend you do your own resume, so you can by doing it you can uh, like make it easier for you to recover in the danger situation. I wouldn't say danger, but in those pressure of the tests. So I would really recommend that you maybe draw this scheme by yourself with the main diseases, so you can use this table also to help you doing that. But I think that's it, guys. If you like the video, subscribe to my channel, and if you have any requests about our team that you want me to discuss or do a class over it, it will be a pleasure to help. And subscribe my channel, like the video, and share with your friends. I hope that helps, and see you on the next video.